All right. Welcome everyone to tonight's live stream, Redefining Menopause, your guide to hormonal harmony. My name is Laura Santuri, and I am the Executive Director of the Interstitial Cystitis Association. The ICA is the only national nonprofit organization in the U.S. dedicated to the IC-BPS community. And to learn more about us and the services that we provide, I encourage you to visit ichelp.org. The ICA is very pleased to be presenting this webinar with two incredible speakers who I have the privilege of introducing. Dr. Rachel S. Rubin is a board-certified urologist with fellowship training in sexual medicine for both female and male sexual health and serves as an assistant clinical professor of urology at Georgetown University. Dr. Rubin is the former education chair and current director at large for the International Society for the Study of Women's Sexual Health, and she serves on the editorial board for the Journal of Sexual Medicine and the Video Journal of Sexual Medicine. She contributed to the 2025 AUA guidelines on the treatment of genitourinary syndrome of menopause. And most recently, she was successful in advocating for the removal of the black box warning on vaginal estrogen. Our second speaker, Heather Florio, CEO of Desert Harvest, is a leader in women's pelvic and sexual wellness. With over 30 years of experience, she has driven Desert Harvest's 1,500% growth, providing science-backed solutions for pelvic pain, sexual dysfunction, and IC-BPS. Committed to research and education, she empowers individuals through safe, effective, and compassionate care. So without further ado, I'm going to turn things over to these two wonderful speakers.
Thank you, Laura. All right, Rachel, let's get started here. Thanks for being here. I really appreciate you taking this time. I know you've been extremely busy. So let's start this off by starting to learn a little bit more about you. Could you briefly share your journey in urology, sexual medicine? What led you to focus on hormonal issues, bladder, pelvic pain conditions, and sexual health?
Yeah, I'm so happy to be here. This is really fabulous. It's such an important topic, and this community is so important. And I just love the growing voices in this space, and how we're having a moment and a day. It's not just a day though; it's kind of been this like wave of interest in these topics. It feels like we've been yelling about it for forever. And to have the head of the FDA and HHS get on stage to say, hey, these issues are important and they've been ignored for too long is truly revolutionary. My journey is an interesting one. You don't really dream of being a penis doctor from when you're a little kid, but yet somehow you choose the strange paths that get you where you are. I loved urology because it dealt with quality of life issues, sexual medicine. OBGYN wasn't quite for me. I didn't really like delivering babies, although I really enjoyed other aspects of women's health. I have the personality for it. When you're a urologist, you can say as many bad words as you want. And it really, sexual medicine was just a really fabulous topic that I found myself super interested in. I would love some water at some point, if you could get me some, please. And thank you. It really was this journey, and I had really good mentorship. And sexual medicine, really, we deal with a lot of pelvic pain, we deal with a lot of bladder issues, obviously, and so there's a lot of overlap in our interest in hormones, in pelvic pain, in sexual health, and sort of where those Venn diagrams sort of all come together.
Perfect. So many people think that menopause or hormone therapy are just hot flashes and night sweats, but your work emphasizes a much broader profile of issues. Could you explain how hormonal changes intersect with bladder and pelvic pain and sexual health within your practice?
Yeah, absolutely. It's so important. And we really don't think about this enough. And that's why I'm very grateful for all the press menopause is getting, because it truly does have a terrible PR campaign in this thought of like, oh, it's this short period of time with hot flashes and night sweats. It's a short period of time and hormones are dangerous, so I can't even consider them. And my doctor never mentioned it to me. And the labeling says that it's dangerous and it's going to cause cancer, stroke, and blood clots. And none of that is true. And sort of doctors now don't really know how to teach you about it, because we stopped teaching it in medical school. We stopped teaching it in residency, which is, again, crazy in what we're trying to change. But truly, you have hormone receptors in every cell of your body: estrogen, progesterone, testosterone. when you are of reproductive age, you're filled with hormonal to capacity with sort of your hormone receptors. And then there are things that we do to change hormones, and there are consequences to those changes. So things like birth control pills can alter the hormones in your body. Pregnancy, obviously, and breastfeeding can change your hormonal state. Acne medications, over-exercising, and then perimenopause and menopause is sort of this kind of abrupt decline and then sort of complete castration of your sex hormones, which, yes, comes with hot flashes and night sweats, but your bladder is full of estrogen and testosterone receptors. And when those receptors get wonky in terms of the hormone levels they have, that can cause frequency of urination, urgency of urination, irritation, burning, and itching. And so if you're someone who developed your interstitial cystitis in your 30s or 40s and beyond, hormones should be number 1, 2, and 3 on your differential of what you could do to support your bladder health. And so there are many causes, as we know. Interstitial cystitis and bladder pain can be a pelvic floor muscle issue, it can be a bladder lining issue, an ulceration issue, but hormones are an incredibly under-discussed issue when it comes to pelvic pain and bladder pain in particular.
Perfect. So that leads me into my next question. So GSM, the genitourinary syndrome of menopause. Flora, and that was talking about this tongue twister earlier. You have a fantastic guide on it. Could you walk us through how vaginal estrogen or other localized hormone therapies play a role even in patients whose primary complaint might be urinary or bladder issues rather than classic menopausal symptoms?
Absolutely. And this is so important because genitourinary syndrome of menopause, or GSM, the name isn't perfect because it can happen not in menopause. It can happen in perimenopause, during breastfeeding, if you're on birth control pills, if you take spironolactone. There are so many things that can cause these GSM symptoms. And actually, we just added a whole page. My team is amazing. They just added a whole page on our website just about GSM. So if you go to rachelrubinmd.com and hit the GSM button, genitourinary syndrome of menopause is so many things. It's frequency, it's urgency of urination, it's bladder pain, it's irritation, burning, and itching of the vulva, it's vaginal dryness, it's recurrent urinary tract infections. And the change, it's not just symptoms, it's also, you can see with your eyeballs, you can see the labia minora shriveling up and resorbing, you can see the clitoris size change, you can see the vulvar vestibule, which is one of the most important body parts that people with interstitial cystitis should know about. It's the lining around the urethra at the vulvar opening. That's actually bladder tissue as well. And it can be really irritated, burning during these hormonal changes and for other reasons too. And we find a lot of interstitial cystitis origin in that space. It can be vaginal dryness. You can change the vaginal pH, which can increase your risk of urinary tract infections. And so all these signs and symptoms, we were able to put into a guideline together to say, okay, here's how you diagnose it, here's how you treat it, here's what your doctor should be doing. And it's a guide for your doctor to say, hey, this is evidence-based medicine. This is the American Urologic Association. You have to know this. This is your job. And we've put together free trainings, tons of them, on GSM for your clinician. We even have a provider's pocket guide. So you could hand this piece of paper to say, hey, this is how you write the prescription, or watch Dr. Rubin's videos on YouTube. And so we're hoping that that changes sort of people's ability to get this really important therapy faster.
Perfect. We will make sure we get a link on Desert Harvest website for that. Definitely our entire audience needs to know that, and probably the Interstitial Cystitis Association as well. So how do you evaluate whether someone is a good candidate for hormone therapy, systemic or localized, versus non-hormonal approaches? What are the red flags or counterindications you look for?
Yeah, it's a great question. So when we talk about hormone therapy or hormone replacement therapy or menopause hormone therapy, you want to work with someone who can speak the lingo and really has a couple options in their toolbox for you, because the details and the nuances kind of matter here, and how your doctor talks to you about it also really matters. So there's sort of whole body menopause symptoms: hot flashes, night sweats, brain fog, irritability, skin changes, depression, anxiety. These are things that can really happen in the perimenopause and menopause time period. And then there's the local symptoms, like the vaginal and bladder symptoms that we call that kind of localized GSM symptoms. And treatments can be different. You can treat just the GSM with local vaginal hormones, which don't go through your whole body. They don't help with your hot flashes. They don't protect your bones from osteoporosis. And those local treatments, they are, I would argue, essential and safe for anyone who has any kind of bladder or pelvic symptoms. They should be tried. Like I actually probably am more aggressive. I might be the most aggressive human on earth in this space. But when I teach people how to do this, I really think of, what are you afraid of? And the answer is, I'm never afraid of vaginal hormones to support the genital and urinary health. So if you are young, if you are old, if you are on any treatments of any, like, there are no patients who don't deserve vaginal hormones, especially if they have IC symptoms, or and sometimes it's finding the right product for you, because sometimes not everybody tolerates all the products, and there can be chemicals or things like that in different products. So there's the local symptoms and the local products, and then there's the whole body products as well, which don't necessarily help the bladder symptoms as much. And so some people, if you have hot flashes, night sweats, if you would love osteoporosis prevention, if you want some libido improvements, that's when we start talking about whole body estrogen and progesterone and testosterone therapy.
Okay, so for those patients that are concerned about the long-term risks of HRT, the old science, why don't we talk about the current evidence-based perspective, the risk versus benefit, and let's talk about the recent shift and change. We alluded to the black box warning. Let's delve deeper into that.
Yeah, so this is fascinating, right? On Monday of last week, there was a big giant announcement out of the FDA that said they are removing the scary warning labels on all estrogen products. And so if you've ever been given a prescription for any kind of estrogen, whether it's local low dose vaginal hormones or a patch or an oral estrogen, there is a big scary warning that says, careful, this causes stroke, heart attacks, blood clots, cancer, and probable dementia. Now, the problem with that warning label was that it was placed in 2002 or 2003 after a big study called the Women's Health Initiative came out. It was a $1 billion NIH study. And that study was kind of misinterpreted and didn't even say any of those things. It didn't say it causes stroke, blood clots, heart attack, breast cancer, and probable dementia. In fact, it was a lot more nuanced than that. And what the study actually showed was that if you use those hormones and you use them in the right setting, which is early, below 60, they actually can prevent fractures, prevent diabetes. They can decrease your risk of cardiovascular disease. They can decrease all-cause mortality. There was so much benefit. But all that people saw were the negatives and the harms that actually were misinterpreted by the study. And so this label got put on, and for 20 years, nobody demanded the label get removed, not because it was scientifically accurate, but because, let's be honest, my friends, there's always something more important than women's sexual health, their menopause health, and their quality of life. Like, no one is making menopause hormone therapy and quality of life their top priority for 20 years.
Yeah.
And so it just got ignored. And they were like, well, it's fine, we're protecting women. But they weren't protecting women. They were actually hurting women deeply, because urinary tract infections and osteoporosis kill the people that we love. So while we can't quantify how many women have been unnecessarily hurt by these labels, it's not insignificant. And so we've done a lot of lobbying, not just myself, but many, many people. We had more than 20,000 signatures. We had all the medical societies. We really did a big campaign. And I think luck and a prayer sort of gave correct timing, because the current FDA commissioner had written a chapter in his book about blind spots, about hormone therapy. And he was really interested in sort of making this right. And so it was, I think, as luck has it, he was in a position to really help push it through. And they had been working on this at the FDA, sort of in the trenches, really trying to make a new warning label. So the warnings are not completely gone, but the big scary labels that say, oh my God, this is going to kill you, those are going away. And we know that vaginal hormones are incredibly safe for pretty much anyone. So if you are someone who's had bladder pain, urinary frequency, urinary urgency, any kind of pelvic pain issue, if you haven't used vaginal hormones because of fear, it's enough already. The fear, there shouldn't be fear. We have more data to show life-saving benefit than we have any data to show fear. And so that's what my priority and my mission really is how can I convince your mom, your grandma, you to say, hey, not using vaginal hormones is really affecting the quality of your life. It is making so you cannot get out of your house, that you cannot, be intimate with your partner, that you cannot do the things that you want to do. It is affecting the quality of your life. And you must not only consider it, but use the right dose effectively for long enough, for actually forever. These are products that you will use for the rest of your life. So it's finding the right product that is right for you.
I love that. Yeah, I take HRT myself, and as an interstitial cystitis patient, I cheer it on. I'm constantly always asking women, are you on HRT? Are you on HRT? And it's surprising how many say that they're not.
And
so
it would be such an important patient population to study of
Mhm.
what is the regimen that, again, all of the things are not going to work for all of the people. And no
Mhm.
one is suggesting that is the only treatment that you should use. But the way I think about it is sort of like the foundational element, the bladder, the vulva, the vagina, it foundationally needs hormones to be strong and healthy, like a plant needing water. And so it becomes, if you don't have, like, you can't give plant food and no water. You can't give, sort of a beautiful plant extra thing and no water. Like, it needs water as the foundation. And then you can do the extra steps that will help the plant thrive. So I think that all of the IC toolbox would work even better if you have the foundational hormone elements in place.
And that kind of leads me into my next question, because patients that present with bladder pain, pelvic pain, like interstitial cystitis, bladder pain syndrome, how often do hormonal changes or menopause related shifts contribute to the worsening of those conditions?
So honestly, I think a lot. I think it happens a lot. So when we see patients in our clinic, the big patient population that would have gotten a diagnosis of interstitial cystitis, but in my hands, I question that again, Hunner's lesions, but absolute bladder, of course. But I see patients who are on birth control pills that have interstitial cystitis symptoms. And if you I saw one today who we stopped her hormonal birth control, and she stopped her spironolactone, and her pain got 85 to 90% better. And she was sitting there. It was so fun. She was like this early 20 something. She had pain everywhere on exam. And then I saw her 3 months later, and she had just pain in 2 tiny spots. And she said, yeah, my burning has gone away. My burning with urination is so much better. She understood, she saw it. And then she saw those 2 spots that were her only spots left of pain. And she just kept saying, slay girl. Like, she was so excited. That's what the kids are saying. And she was so happy and she saw that, like, she had only been off her spironolactone for a few weeks, that we're going to give it more time, with our topical hormones that we're using. So we see it in this birth control population. We see it in this perimenopause population. Like, you're still getting your periods, but all of a sudden you're in your mid to late 30s and you just start getting UTIs, you start getting pain, you start getting urgency, and you're like, what the heck, right? So we see it in those population, where I personally hypothesize that that's an androgen problem, because your testosterone is starting to fall. So not even a menopause problem, but sort of a testosterone problem. And then, of course, we see women in menopause all the time who they can't have sex, they can't leave their house because they're peeing all the time. They can't make it through the movie. They can't pick up their grandkids because they're leaking. And there certainly is a lot of pelvic pain that can go with that as well. The other population I will say that I see that I think is less hormonal is the endometriosis population. I think we see a lot of scar tissue from the internal scar tissue that is attacking the bladder from the inside, or sort of the outer layers of the bladder as opposed to the inside layers of the bladder.
Yeah, it was actually really interesting. We were doing a clinical research study in Italy, and the doctor showed me that they found it on the back side. They had to do a laparoscopy, an exploratory, and they found it on the back side of the bladder. And I was all like, wow, I've never really thought about how it could impact from the outside of the bladder.
So if you're, and I think that's the problem is the bladder, right? It's got muscle layer and then the internal lining. And we all think of the internal lining when we think of IC, but actually if you have scalding scars on the muscle outside of the balloon, on top of it, it's almost like you're taking like a hot poker from the outside. And so if so then if you think of the bladder like increasing and decreasing and you've got scar on the outside, it's going to cause pain. So I think we don't think about that enough. And we always blame the inside lining of the bladder, which I don't think is always the case. And then, so if your symptoms are cyclical, and they're worse during certain times of your period, that's when my spidey brain says, something's not right here. And we start talking to endometriosis specialists. And so I think the challenge, there's so many challenges besides the fact that no one cares about women's health or studies it or researches it or puts any money towards it. But the other problem is, depending on who you go see, is if they don't have the whole toolbox to offer you, or they don't show curiosity about the whole toolbox, that becomes a challenge, right? I'm not an endometriosis specialist, so I could easily keep people in my clinic and just say, I'm just going to throw you the things that I know how to do. But because, and I'm certainly not the best in the world at this, but because I spend time listening, I said, I'm hearing endometriosis, your symptoms, they're cyclical, they're this, they're that. And I'm like, maybe we should bring in an endometriosis specialist here.
Yeah, I think that they call it the evil twin of interstitial cystitis. And I think it's something that's very overlooked for a lot of women as far as endometriosis goes.
And it's a big deal because you have to get, right now, again, you have to get surgery in order to get diagnosed. And it can't just be surgery with anyone. You need someone who has eyeballs and curiosity and who actually knows what they're looking for. And so to be a patient, to be a woman today in today's medical world is a nightmare, right? It is a nightmare that we think a 10-minute office visit is okay. It's a nightmare that we think our doctors actually know us, or that they care enough to think through complex problems, that they actually hear what we're saying. And so you have to be your own advocate. Sadly, you have to not let, one bad medical visit deter you from finding what you need to do to get relief. And I think that's the case here. And thank God for organizations like all of yours that really push education and thought leadership to say like, yes, and like, what are the different tools that we can get to hear our patients, to hear what's working and share that information loudly.
Yes, I mean, we shout it from the rooftops. I mean, we can't do exploratory laparoscopies in the United States. I don't think insurance companies would allow that, but that's the one of the positives, but there are also negatives of the socialized medicine. But I think that they get to explore a little bit more over in Europe than we necessarily get to here with the limits of insurance. So but that leads me into my next question. Let's talk about sex a little bit more. So you treat all genders in sexual medicine, from the hormonal, pelvic health side. What are the most under-recognized contributors to low libido, arousal issues, orgasmic dysfunction, and pain during sex? How often are hormones or, bladder part of the picture?
Oh, no. I mean, the thing is, if you're having pain with sex, like, why would you have a high libido? It doesn't make any sense, right? Although every once in a while I will see a patient. This is how you know biology is really, really strong, because I will see some people who are like, it hurts so bad, everything feels like shards of glass, but I still have a libido, I still have an interest. And I was like, damn, that's pretty incredible. Like, dopamine has to be pretty poppin' if that's the case, because how often do you put your hand on a hot stove, right? You're never going to do it. Your body's going to pull away. So I think libido, if you have pain, it's really hard to have a great libido if you have pain. Now, we also have to remember that most most women do not orgasm from penetration, that it's typically from clitoral stimulation. So if you do have pain with penetration, but you can still orgasm, we encourage intimacy and touch and orgasm and pleasure and like whatever we can do to find the good parts, the good things that feel good, a massage, a bath, whatever. But if you're in pain, like that needs to be addressed and that needs to be figured out. And you have to get a team together, like a pit crew together to figure out, is this muscle, is this tissue, is it hormones, is it nerve, sort of what is causing your pain. And I would say hormones are a huge, huge offender of pelvic pain and should always be ruled out, meaning it should always be added to the treatment strategy as the foundation. And then the other stuff, as I say, it declares itself. So the pelvic floor muscle tightness can never relax if the hormones are a problem, right? So you treat the hormones and then you go after the pelvic floor. If you have, now there are some people who have mast cell conditions that those are challenging and not always responsive to hormones. And so there's different things that we'll do for patients. And that is another sort of issue that really needs more research and funding and understanding because there are many, many patients suffering. So I think hormones are a huge, huge foundational part of this. We know testosterone is important for libido. We know that different things can affect. We know different medications, antidepressants, different pain medicines can definitely hurt your sexual health. So again, it all is what we call biopsychosocial, right? Your biology. And we do a lot of talking about the psychosocial pieces of this, right? And we think we can control it all if we just do more yoga, meditation, mindfulness, eat better, exercise more. All of a sudden, our sexual health is going to be improved. And we minimize biology. We minimize hormones. We minimize biology. And that's part of my whole thing, is just not minimizing the psychosocial stuff, but maximizing the biology and really trying to say, what can we do to help on the biological side?
So when we talk about, let's say, you mentioned testosterone, we've talked about vaginal estrogen as it relates to sexual function and sexual health as it relates specifically to hormones. What areas are we trying to, you mentioned testosterone and libido, vaginal estrogen. How can those individual hormones tackle different components of sexual
So
function?
when we talk about hormones in general, I sort of break it down, and this is an educated audience. So sometimes I say it's 4 things, but for this audience, I'm going to do the extra credit one, which is there are really 5 things you need to think about. And so there is whole body estrogen therapy, like an estrogen patch, a gel, potentially an estrogen pill, although they're not my favorite for sexual health. So the through the skin estrogen, like a patch or a gel, tends to be my preferred approach, but those can improve your libido. So that you don't have hot flashes, you don't have night sweats, but even on their own, we see a boost in estrogen can help with libido. Now, the second thing, so that's one, the estrogen for your whole body. Progesterone, if you have a uterus, the progesterone counterbalances the estrogen. So you can get uterine cancer if you don't use progesterone with your estrogen. But even sometimes in patients who don't have a uterus, we will still give progesterone therapy.
Such as me.
I've been talking a lot this week, you guys. And so that can also help with sleep for some people and anxiety reduction because of the way it works on the GABA receptors of the brain. And so we do find that can help with your sexual health. If you're not sleeping and now you get some sleep, who doesn't have better sex when they're well rested? Testosterone, that's 2. The third one is testosterone, which we know improves libido, but also you have testosterone receptors in your bladder, in your pelvic floor, all around your vulva. Your clitoris is full of testosterone receptors, so it helps with arousal, it helps with orgasm. So whole body testosterone is often discussed. Now, you may not start all these things at once. You may sort of gradually increase, but it is not uncommon for me to ultimately have patients on 5 different therapies. Now, the fourth one is vaginal hormones. So vaginal estrogen or vaginal DHEA is even a little better if you can get insurance to cover it, because DHEA is the precursor to both estrogen and testosterone. So we do love it for UTI prevention and urgency. I think it probably is if you are on vaginal estrogen at a good dose and it's not fixing your bladder symptoms, you may want to switch to vaginal DHEA as to see if that rescues you. And then the fifth, so vaginal hormones is the fourth. And then the fifth one, which I don't always talk about to every audience, is vestibule hormones. And that's that vulvar vestibule, that tissue that surrounds the urethra. Sometimes we will compound. It's really the only place where I compound hormones, a little bit of estrogen and a little bit of testosterone, and rubbing it on that vulvar vestibule tissue has truly cured so much interstitial cystitis in my practice. It's truly remarkable. And so I wish there was an FDA approved product that I could give you that would magically do that. But the vaginal DHEA is close. The vaginal DHEA actually can help with this tissue as well. Estrogen cream can help a little bit with this tissue, but I do think adding that testosterone piece can be game changing for people.
Perfect. And this will align with one of these questions that we have over here and talk a little bit about also the new Desert Harvest product that we were just talking about at AUA this past spring that we've now just introduced in the past month. So there's a growing interest in non-hormonal options that may help women navigate, from pelvic floor physical therapy on. And one of the things that we just introduced is the human bioidentical lactoferrin formulation from Desert Harvest. How do you find this kind of supplement strategy in addition to HRT with lactoferrin supporting iron balance, vaginal bladder mucosal health, immune microbiome health, in the context of hormonal changes and the genitourinary symptoms of menopause?
Yeah, I mean, I think it is certainly, I think studying all these things and getting some data, right? I'd love to see sort of how they work alone, how they work with hormones in conjunction. I'm all for trying different products, and I love science. I love new science. I love learning new things, and I am always open to learning new things. I think where I get, my only hesitation is sort of hormones. Vaginal hormones are so safe. They're so safe for everybody. And while we can look at all sorts of different things to help women, we need to really do a better job of explaining to people how safe these vaginal hormones truly, truly are. And the more we can do that, the more, yes, we can try new things, but people shouldn't be suffering because of the fear of vaginal hormones.
Perfect. Yeah, and I'm definitely need to send you some research. We've got all of our latest and greatest research as it relates to menopause and iron balance as it relates to estrogen production as well.
Fabulous.
So I definitely need to send you that. And this isn't your typical bovine lactoferrin it floods the market. This is the first of its kind human bioidentical. So it's meant to function the same in the human body, whereas a cow is not necessarily going to function the same way in a human body when you take lactoferrin from breast milk from cows. And so that was where, for me, it was really important to bring this out, having, because all the products that are out there, we can talk about yams and maca maca and all these other things like that, but the evidence is very minimal, and the benefit is very minimal. So it was very important to me. That's why, in 33 years, this is the first menopausal supplement that we chose to bring out specifically because we have so much safety data and research behind it to support it. So I'm sending that your way after this. But and as those that may not, I'd like to kind of talk a little bit about the risks. For those people that may not be able to, how might you incorporate or evaluate adjunctive measures like the lactoferrin, mucosal support, other things like that? What caveats or monitoring would you recommend for those that can't necessarily have HRT, the small percentage of the population?
Yeah, so I think, for whole body hormone therapy, there are some new FDA medications that can help with hot flashes and night sweats, even sleep. Supplements are one of those things that We need more data. We need more
Mhm.
people like you doing the research and studying this, and we need those supplement companies to do the work to show, to show the efficacy. And that's why we love, we love companies that do take the science seriously. It's the best thing ever, because not a lot of people take science seriously when it comes to women's health issues. So I think when it comes to the genital and urinary symptoms specifically, there really aren't supplements that have come out as a home run on the GSM side that we can strongly recommend. This was reviewed at length by the guidelines committee. We know moisturizers and lubricants are fabulous. I recommend often, different products that you guys have for moisturizers and lubricants. Obviously, you want ones that aren't irritating and harmful, and they're good. They're Band-Aids. They help. They absolutely help and should be used liberally. It's also just, wanting to fix the problem, which is where, sort of vaginal hormones come in. Things like lasers and vaginal lasers and things like that. Our take is you really, the data is just not fully there yet to say that there's home run sort of, and they're very expensive. And so we do say caution, with those types of treatments. But that's kind of where the space is for those types of issues. And again, it's having those, so many patients will say, well, I can't do this because of X, Y, and Z. And those actually aren't reasons that they can't do it. And so it's a challenge because, you're one doctor that you see for so long and they say, oh yeah, your family history, you can't do that. They actually aren't right. And that's not correct. And so that's where, really looking into your own specific story with someone who can actually really work with you and say, well, is it really a no? And is this something worth trying? And that's the challenge, is whether or not you think it's worth trying.
Yeah, I definitely agree wholeheartedly with that. And I think like when we talk about vaginal moisturizers, the one thing is not everything out there on the market is meant to go into the vaginal biome. It's meant to make money for someone, but it's not necessarily meant to go in the vaginal biome. So just be very careful. Separate of pH, you've got osmolality, which is osmolality is so crucial because this is how the fluid flows in and out of epithelial cells of your vaginal wall. And I always caution people, there are only a few products as far as vaginal moisturizers that are truly pH balanced and isoosmolar. And so do your research, ask the questions. They have to do this to put this on the market for the FDA. They have to do this testing. They know their osmolality number. Ideal vaginal osmolality is 290. World Health Organization, the only study that's been done says plus or minus 80 points from that number. So be wary of what you're putting inside your vagina. That's all I have to say about that. And then let's talk about, for practitioners listening tonight, let's go outside the box here. If a patient presents with sexual dysfunction, bladder pain, pelvic pain, suspected hormonal transition, what would you say is your 3-step approach or algorithm for those patients?
Oh, I love that question. So my very simple 3-step algorithm is: one, a history, is talk to your patient, talk to them at length, figure out, when did this start? Did you always have it? What are your symptoms? Describe it for me. What bothers you the most about this? What are your goals? What's worked? What doesn't work? History, the patients give us the answers every single time, right? If you spend long enough talking to someone, they are the detectives. They get it. They've done their research. Like, they give the answers away in the story. So history is the most important thing. The second most important thing, which your doctor doesn't always know how to do, is a physical exam. And this is really wild. They do not teach us. I know you want your doctor to know everything, and I know you want your doctor to be ChatGPT and have unlimited knowledge of the human body, but they did not teach us about the vulva in medical school. They don't teach us anything about the vulva. They don't teach us anything about examining the clitoris, the urethra, the vulva, nothing. And so most of your doctors don't do this routinely. And so if you go with bladder symptoms, even urologists, I did urology training, right? Like, I help to teach the urologist this piece of information, but they don't all get to learn from me. But yes, it's not really taught in urology school, in gynecology school. Like, they don't get a really great understanding of things like the vulvar vestibule and how to examine it. So if you don't have a doctor who is examining your vulva, who isn't looking at your vulvar vestibule and touching it with a Q-tip, who aren't trying to find your pain, that second thing besides the history is they need to find your IC. Where is your IC located? Can they touch it? Can they understand where you do have IC and where you don't have IC? So honestly, where you don't have pain is so important, and they should push on that part. Where you do have pain, they should push on that part to understand, okay, what lives here? Is this the bladder? Is this the urethra? Is this the vestibule? Is this your pelvic floor muscles? Because I swear, when I touch your pelvic floor muscles and you say that feels like a UTI, I'm not causing you to have a UTI. So your muscle tension, right, is causing this UTI sensation. So it's the exam is such, and it needs to be a rich, detailed exam that really does explore your pain. So if your doctor has never examined you, which I suspect many of you have had no exams and just diagnosis without exam, to me, you have to find a different doctor, because you cannot do interstitial cystitis medicine through telehealth. You just cannot do it. Like it is not appropriate, and you deserve a diagnosis and a hypothesis of what's going on with you. And then the third piece is a good treatment plan, right? Is a toolbox of ideas that is going to roadmap and help you. And not every tool works for every person. And what you want your doctor to do is to say, hey, with your story, with your exam, my thought would be we start here, but we then think about this, 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 and this. And that's what my thought would be for you. What do you think? And is that something, do you agree with that? Because when your patient can see, and again, during that exam, we give mirrors to people and we're examining with the patient live, and we show them where their interstitial cystitis is of, look, when I touch here, you have horrible symptoms. When I touch a millimeter over, you have no symptoms. This isn't in your head. This is in this part of your body. And this is why I think it's in this part of your body. I didn't realize, I have a lot of gray hair. I've been doing this a while, but I didn't realize how much medicine was in that approach, how just showing people my thought process and where I can find their pain is medicine. It is, because when you feel like you know what's going on, everything feels easier, right? When it's like this sort of scary, dark cloud of, oh, I just don't know what this is. Nobody knows what this is. I'm a medical mystery. Oh my gosh. And you cannot control it. When you feel like you understand what the problem is, it will make perfect sense. That young woman this morning who kept saying slay girl because she was so excited, she saw exactly where the two spots of pain were left, whereas it used to all be painful. And in her mind, she was not panicked anymore because she saw the progress. She saw the improvement, and she understood that more time was going to be her friend, that we didn't need to rush to a surgery or something like more aggressive, and that she saw, oh, I get it. You had a theory. Your theory is working. We're going to continue on with your theory. And as soon as your theory stops working, we're going to switch to a different theory. And her brain understood that. So her frustration and fear were so much lower because she understood.
So that leads me into my next question. Let's empower the patients here. When they are in the doctor's office, what are their must asks? If their doctor, they suspect hormones, their bladder, sexual function, and that they're all interlinked, what should be their must asks when they go into that doctor's office?
I think compassion for your doctors, we don't talk about enough, because we are angry, and we should be angry. I'm angry with you that your doctor doesn't know all of these things. But take a minute and remember how bad it is for your doctor. Your doctor never learned this part of anatomy. Your doctor never got a class on interstitial cystitis, not one. Your doctor never got an understanding of the algorithm for interstitial cystitis. So if your doctor is kind enough to read the AUA guidelines on ICBPS, they're probably the best doctor you're ever going to sort of talk to and meet with. Most of them haven't done that. And so the key to finding a good doctor is someone who knows they don't know this. honestly. It's someone who knows that they're not an expert in this and doesn't dismiss you for coming up with ideas. The doctor who says to you, wow, this isn't my expertise, but let's look through this together. And oh, this hormonal idea, that's a fabulously interesting one. And I know this is safe to give you vaginal hormones. So wow, let's do this. Let's try this. And oh, maybe let's send you to a specialist who, does do this a little bit more and with a little bit more confidence. The key is don't work with a doctor who makes you feel bad about yourself, who makes you feel bad for asking questions or for bringing your own research or your own especially if there's like guidelines. If you bring someone my GSM guidelines, which are an American Urologic Association, and the IC guidelines, American Urologic Association, if you bring guidelines and they dismiss you, they are not the right people to work with, right? And that's really the key. So I think it sounds crazy, but you got to work on your vibes with your doctor. Like, you want to see a doctor who shows brain cells that they're curious, that they're interested in, they can learn new things, and that they care about you and they want to help you. Those are the people you want to work with. Anyone who makes you feel small or makes you feel shame or guilt or like you're doing something wrong or this is your fault, goodbye. They do not serve you, and you cannot go back. It's okay.
Thank you. Yeah, that'll really empower patients as they go into their doctor's office. I appreciate that. And then lastly, let's give them some hope for the future. You're knee deep in this. So what are the most exciting developments or bright lines that you see in the next 2 to 3 years in the field?
Oh, geez. Listen, I've never been paid so much attention to in my life. This week has been truly unbelievable in how much press, attention, and excitement is around hormones. And that is revolutionary. The colleagues of mine, we've been yelling for years, what feels like decades now, about the importance of these issues. So with social media, listen, Apple just today came out with their most shared podcast episodes for the whole year, and 3 out of the top 10 were about menopause. And so this isn't going away. This isn't going to be like, oh, this year was about menopause, next year is going to be about something. Like, this is here. And I think women are waking up. They are saying, why don't I feel like myself? Do I have options? Why isn't my doctor giving me options? What does the research say? And what should I do with my body? And I'm hopeful that gives me a lot of hope, actually. And when you have the head of the FDA actually get on every news channel to talk about menopause, that in and of itself is revolutionary, right? Whether you agree with his politics or not, that fact is revolutionary. And so I am a hopeful. I'm cautiously hopeful, because we have a lot of work to do. We have a lot of unanswered research questions. Every day I have 27 million more ideas of what needs to be studied. And I spend most of my day with patients being like, well, we're going to use logic because I don't have data to share with you, but I'm going to use logic to try to figure this out. And here's what I think we should do. I would love a research institute where we can start answering those questions, where we can actually do the studies, because I'm not sure the NIH is going to fund so much, about these topics. And so we have to find ways to get answers to questions. I think that the more we shout and scream and talk about these things in podcasts, in live sessions, someone's listening that's going to solve a problem. Someone is listening and they're going to champion a topic and a research thing. So I think all the awareness out there is really helpful, because I am seeing research get published that is about topics that I know we talk about on social media, that I didn't do the research. Other people are doing research because they're watching what we're talking about and they're seeing it. And that's extremely, extremely hopeful.
Love it. So we do have a few questions here, and we have a few more minutes. So I'm going to throw out a few of these questions here, see if we can answer a few of them. So can Dr. Rubin share the percentages of hormones in the vestibule cream, or what you recommend? Is there a reference or an article on that?
Yeah, absolutely. So we typically recommend a 0.01% estradiol. Now, some people use 0.02. It doesn't matter. It's like the same in estrace or a generic estradiol cream. So like a 0.01% estradiol. And then we use a 0.1% testosterone. So 0.01 estradiol, 0.1% testosterone. Now, when we use testosterone for libido, it's 1%. So this is 10 times less. This is truly microdosing. And then we typically put it in a base that our patients tolerate. So it might be a Versa base or an Alage base or a methyl cellulose base. And they rub it on their vestibule every day. And you got to show them where their vestibule is, because most people can't find their vestibules because they've never had it pointed out to them. And so you really have to spread the labia minora pretty wide. And it's the area all above and around the urethra and the vaginal opening.
Love it. Okay. And this goes to the last point. So you mentioned all these great things the doctor should be doing. How do we find these doctors?
Yeah, so the best group that I know of who really understands this stuff pretty well, now just because they're on the website doesn't mean they do all this perfectly, is as someone who cares about ISSWSH. ISSWSH.org. ISSWSH is the International Society for the Study of Women's Sexual Health, ISSWSH. And so they have a find a provider, and those people are fabulous because we do a lot of courses. We do a lot of pelvic pain work. We have online courses to teach pelvic pain. We have hands-on courses to teach pelvic pain, and our membership has grown significantly over the years, which is really excellent. And so if you can find someone in your area that is ISSWSH trained, that's a great place to go. If you're looking more for menopause hormone therapy, you can go to menopause.org, the Menopause Society. They may not be as educated on vulvar and bladder symptoms, so you do want to be cautious there. If you can find a woman urologist, so not necessarily, sometimes a urogynecologist can help, but woman urologists tend to be, I'm a woman urologist, so I'm extremely biased here, but I find them to be the most resourceful, compassionate, interested in trying things people kind of I've ever met. Like I can be in a Facebook group with a 900 women urologists and I can say, hey, this worked for a patient, and everyone will do it the next day and will change lives. Like they will adapt very quickly, which is very cool.
I love the conferences so much. I'll answer this one just a little bit. This could be completely biased, but what are some names of lubricants you recommend? Desert Harvest Aloe Glide is isoosmolar at 308. Remember that 290 vaginal osmolality plus or minus 80 points, and is pH balanced at 4.5. So that is the recommendation that I would give. And then separate of this, I'd like to kind of delve into this because we didn't really talk about this just a little bit, and we'll leave this kind of as our last question of the night. So we have two people that are talking about flares. One, she's 60 years old and finds sex really brings up a flare up. And then also when she's highly stressed, she's getting a flare up as well. What recommendations do you have there for her?
I love everything about this question because I think it ties it all together. I don't know if she's able to, if I ask her a question, would she answer it in the chat box?
Yeah, let's see.
Okay. Are you on vaginal hormones, estrogen or vaginal DHEA? Let's see if she answers.
She did put later on, my GYN started me on estrus cream 3 times a week.
Okay. And the question I would have for her then, which she may or may not answer here, is how much are you using 3 times a week? Because if you're just taking a little pea size and rubbing it around your urethra, it's not enough. So you have to use at least a gram twice a week. So 1 full gram, it's like the amount on a finger, and you want to rub it into the walls of the vagina. And it's going to take 2 or 3 months to get a good therapeutic dose going. So it doesn't happen quickly. And if you're only using a pea size just around the urethra or the opening, you're not using enough, and it's not going to fix this problem. And so one option is to switch to a vaginal DHEA, a product called Intrarosa, because it's every night and it's very moisturizing and lubricating, and it adds the androgen component. So I would recommend a really good exam to figure out where you're having pain. But what I suspect is if you spread your labia wide and you poke around the urethra at that opening, it hurts you. And guess what a penis scraping against that tissue is going to feel like? It's going to hurt you. And that area is all bladder tissue. It's wide open bladder tissue that's being irritated by friction. And so it's flaring you like crazy because it's literally taking a cheese grater to your bladder over and over and over again. And then ejaculate just irritates it even more because it's a basic material that also kind of messes with your microbiome. So of course, sex is going to flare this thing. And then what does stress do? So having a sunburn at the opening of your vulva that's irritated by sex, and then the pelvic floor muscles that surround the tissue are tight, tight, tight. So when you're stressed, listen, I'm in Washington, D.C. Everyone's a bit of a tight ass, right? Like when you're stressed, it tightens up all your muscles in your pelvis. And so stress is going to tighten up your muscles, which is going to irritate your bladder. So all of it is related. This isn't in your head. You aren't crazy. We're all a little crazy in 2025. I'm not going to lie. Everyone benefits from psychosocial learning how to navigate stress, of course. But there are about 1 million biological reasons that I am certain we could find to cause these flares. And it's such a sad thing because you love your, I don't know if you love your partner, but often I see is you love your partner. The partner hasn't done anything to change. The partners think it's their fault. I had a man in my office today crying because we've fixed his erections and his wife will not go see a doctor to help the shards of glass pain that she feels with sex. And she says, honey, let's just have sex. It's okay to cause me pain. I'm 64. I'm going to have pain. And he's like, no, I don't want to hurt you. Like, I miss my partner. I miss the fun. And he just like wept in my office because he knows there's a solution to help her, but she's not willing to sort of get the help for it. So it's such a devastating situation because I don't know. I think so many people are suffering unnecessarily.
Yes, I agree wholeheartedly. And I've been working with the interstitial cystitis community for over 33 years, and I've watched it evolve from all in your head to actual medicine to this, oh, this is a condition. So
wild.
it
33
is.
years. Oh my God.
Yeah.
I'm not
So
even 33 years old yet. I don't know how that's possible. I'm just kidding. I'm much older. But how is that possible?
oh goodness, and it's been a journey to watch, and we still hear, sadly, it took me 30 years to get diagnosed. We still hear that to this day, and that's a sad state of affairs for women's health. So I really appreciate you coming on here, doing this talk, and providing all this wonderful information to all of these patients. This will be available on all of our socials after this, so we've definitely got some ones that want to go back and read or take it to their doctor and say, listen to this. And so brilliant. And thank you so much, Dr. Rubin. I know you have been pulled in every which way direction. You can watch her on CBS News and everything in between right now. So thank you for taking your time out of this busy week
No,
to help.
It's my pleasure. We have a great newsletter as well on our website because we're always finding out new things and we're always trying to get the research and the education out there as quickly as humanly possible. So please sign up, follow. If I learn something, I'm going to share it right away because what's the point of holding on to this kind of stuff? Like today, oh my gosh, I learned about today. There's a sock that works for neuromodulation. So instead of PTNS or getting an InterStim device, you can put a sock on. Medicare covers it. Most insurance companies cover it. And I learned about it. I was like, why doesn't everyone know about this thing? I think it's called Zida, Zida. But to be able to do, if you have urgency of urination, this is like an amazing option that is no risk, right? Because neuromodulation on a sock is not an implantable device. And so we have to study this in the interstitial cystitis population. We have to study it with hormone therapy. So there are very cool people, doing cool things in this space. And the more we can find out and share the information, the better we science, right? So thank you for having me. This was such an honor.
Thank you. And continue to post your questions online and we'll see what answers we can get for you. And thank you. Thank you so much.